Welcome to our module on urinary surgery with a focus on urinary emergencies. In this module, we'll be covering uroabdomen, causes and emergency management, urinary obstruction, emergency management of obstruction, cystotomy with some tips and tricks, different types of urinary obstructions, and then finally, we'll do a quick diversion into urinary diversion techniques. The clinical signs of urinary problems can sometimes be subtle. Sometimes they're very unsubtle with straining, lack of urination, but sometimes not so clear. They do require aggressive medical management in order to make sure that these patients are stable enough for surgery. Sometimes trauma can be involved in urinary emergencies, and the whole patient has to be evaluated before surgery is appropriate. And general anesthesia may not be a viable option immediately. So talking with the rest of your colleagues and making sure that surgery is the right step is of extreme importance with urinary emergencies. First off, what is the definition of a uroabdomen? Of course, it's accumulation of urine in the peritoneal or the retroperitoneal space, because remember that the kidneys and portions of the ureters actually travel in the retroperitoneal space, not within the peritoneum. So you can have a uroabdomen that isn't in the peritoneum proper. Very commonly, it's a result of a blunt or a penetrating trauma. About 2.5% of all hit by car or vehicular trauma patients will have a uroabdomen. And way more than that, upwards of 39% of dogs and cats with pelvic fractures will also present with a uroabdomen. Another, unfortunately, very common cause of uroabdomen is iatrogenic, so post-operative cystotomy that's leaking or attempts at urinary catheterization gone awry. As well, obstructive disease, so stones that cause upstream obstructions and then leakage of urine can also be a cause. So how do we diagnose a uroabdomen? Palpation, radiographs, not always so helpful. Sometimes even a palpable or a visible bladder on X-ray does not guarantee that the bladder is intact. There can be small sites of leakage, but the bladder is still holding some urine. You can try a contrast cystourethrogram if you have the ability to do so. Abdominocentesis. Excellent way to diagnose a uroabdomen. A 4-quadrant tap can sometimes be helpful if there isn't a lot of fluid, or an ultrasound-guided abdominocentesis can be very, very helpful. When you get fluid from the abdomen, the way to diagnose a uroabdomen is primarily comparing the creatinine and the potassium of the fluid to that in blood. Creatinine of the fluid is greater than 2 times that of the blood, and the potassium is greater than 1.4 times that of the blood. One thing that we look at a lot in blood work to evaluate the kidneys but is not useful for an assessment of uroabdomen is the BUN, or the urea nitrogen. It's a very small molecule that's very quickly equilibrated across the peritoneum, so don't look for that in your test for uroabdomen. Very frequently, I'll get a call with questions about a uroabdomen and timing of surgery. We know it's something that needs surgery, but when does this patient need surgery? Very frequently, they will be dehydrated, they may be azotemic, and they may be in shock. And in those patients, surgery immediately is contraindicated. With uremia, patients can be acutely sensitive to anesthetics, and with dehydration and azotemia, anesthesia can worsen all of those things. Hyperkalemia as well with a urinary obstruction can lead to bradycardia, arrhythmias, and even atrial standstill. These are not patients you want to have under anesthesia. Usually, definitive surgical repair is recommended within 24 to 48 hours of aggressive fluid resuscitation, and sometimes even placement of some sort of peritoneal dialysis catheter or a pigtail catheter into the bladder if there's a patient with a urinary obstruction in the urethra. So there are different ways to divert the urine, and we'll talk a little bit more about that later. Ideally, if a urinary catheter can be placed, simplest is best, and then you can make sure that the amount of uroabdomen does not increase while you're doing fluid resuscitation. In this period of time, diagnostic tests can be performed, determine the extent and the location of injury so you can better prepare for your surgery. So we discussed other methods of diagnosing uroabdomen, but for suspected bladder rupture, contrast cystourethrogram can be very, very helpful. Place a urinary catheter and inject contrast material into the bladder and take serial x-rays to see where the contrast material goes. Once you've diagnosed the bladder rupture, going into surgery and repairing the bladder can be, hopefully, relatively straightforward. The good news about the bladder is that it does heal very rapidly. So if you've sealed your bladder, then the dog or cat should do quite well. You may wish to leave a urinary catheter in for a couple of days for about 48 hours just to maintain decompression of the bladder to allow it to heal. Renal trauma is relatively rare due to the anatomy of the kidney. It has a fibrous capsule, it has a nice bed of perirenal fat. It is a little bit mobile while still being fixed in position, and it is in a protected position, tucked up under the epaxial muscles. But certainly renal trauma can happen either by vehicular trauma or, unfortunately, sometimes with bite wounds. I have seen a kidney cut completely in half like a loaf of bread in a Yorkshire Terrier by a husky. These can be examples of dogs where the signs are not so clear. This dog that I was talking about walked into the hospital, had a couple little puncture wounds, and really was very stable. And the signs of uroabdomen were sort of insidious, and we didn't know until later on. But hemorrhage and uroabdomen will absolutely happen if there's been significant renal trauma. What are some ways that you can diagnose renal trauma? There are some more complex methods like contrast radiography, like an IV pyelogram and fluoroscopy. Not possible in most practices. Same thing with a CT scan. Great to have a CT scan, but a lot of the time that's just not possible. If there is a strong suspicion of renal trauma because of a penetrating abdominal wound, then surgical explore. It's certainly indicated if you have that high index of suspicion or if there's uncontrollable hemorrhage. If the trauma is severe, then unfortunately nephrectomy can be indicated, but again, depends on the degree of severity of injury. Probably the most common reason why we will be doing a urinary surgery, particularly on an emergency basis, is a urinary obstruction. Have to describe and determine a couple of things. One being the location. Urinary obstruction is most commonly intraluminal, right, from stones, something like that obstructing inside the urinary tract. But extraluminal causes, so compression from a tumor, those are also quite common. Etiology can be iatrogenic, again, something that we've done. Urolithiasis, probably the most common. Stricture from a prior obstruction with a stone, we see that in the urethra in cats. Neoplasia, cancer, trauma, foreign bodies, less common. Clots certainly can cause urinary obstructions, and even urethral prolapse can be a cause of urinary obstruction. An important distinction is what's called an upper or a high urinary obstruction or a lower urinary obstruction. An upper urinary obstruction usually suggests a ureteral obstruction between the kidneys and the bladder. These can be a little bit difficult to diagnose. If only one kidney is affected and the other one is completely normal, you may not see anuria or oliguria. You may not even see azotemia. You may not see any clinical signs at all except for a vague malaise. These are usually not surgical emergencies. This is in stark contrast to a lower or a urethral obstruction, in which case no urine is getting out. You'll see anuria, straining, there will be bladder distension, and of course a significant increase in intravesicular pressure in the bladder. On ultrasound, with a lower obstruction, you may also see dilation of the renal pelvis, but primarily this is something you'll diagnose by these quite clear clinical signs. Similarly to other urinary emergencies, with a urethral obstruction or other urinary obstruction, emergency management is very important prior to going to surgery. Performing blood work, fluid diuresis, electrolyte correction, azotemia correction, these are all super important. Catheterization, ideally, if you're able to dislodge whatever it is that's causing the obstruction. Sometimes even a cystotomy catheter. We'll go into a little bit more detail in these. Cystocentesis. If you're unable to relieve a urethral obstruction and you need to make sure that you're getting urine out of a dog or a cat, repeated cystocentesis is certainly an option. Have to be very careful, don't want to lacerate the bladder, but that is a very reasonable option until the patient is stable enough for surgery. Some tips and tricks for placing a urinary catheter in a patient that has a urethral obstruction of whatever cause, whether that's stones or grit, anything like that. There can be some methods to make things a little bit easier. Certainly extrude the penis and inspect it for any grit, any plugs. See if it's very erythematous or bruised, particularly in a cat. See if there's any anatomical abnormalities, such as a urethral prolapse in a dog. The best type of catheter will depend on what you have in your clinic and your personal preference. I was taught to use an open-ended tomcat catheter because it is a little bit more rigid but still quite small in a cat, and pass it very gently with copious lavage and use of lube. You can even place sterile lube in your flush and shake it up so that the saline and the lube are mixed, and that may actually help those stones or anything causing obstruction to pass back into the bladder. And that is called urohydropulsion. So passing a obstruction of whatever sort, but primarily we're talking about stones, into the bladder is pushing that in such that we can remove it via cystotomy and relieve the obstruction. Once you've placed your tomcat, you'd want to replace it with a red rubber or similar catheter of proper length such that it can be sutured in. Ways to help with getting that stone retropulsed or back into the bladder. Using a rectal exam may actually help with dogs. And the way that works is you have an assistant placing pressure on the urethra per rectum while you're flushing from the penis. And what that does with the pressure on the urethra is it dilates it. Dilates the urethra with that flush. And then while you're still pushing on your flush, they release that pressure, and that can be enough to shoot the stone right back into the bladder. So using a rectal exam can be very helpful. Using full general anesthesia. I can't tell you the number of times that I've been able to pass a stone back into the bladder when I've placed a patient under full anesthesia rather than sedation. Why is that? Well, what's one of the most common drugs that we use for general anesthesia? Gas. One of the reasons why we hate it is it causes hypotension. Why? Smooth muscle dilation. And that's of the vasculature, but we want the smooth muscle of the urethra to be dilated as well. So full general anesthesia. Other tips and tricks. If you have access to a hydrophilic guide wire, not one of the ones that has a stylet like for a catheter, for an IV catheter, but a guide wire that's made for these types of procedures, has a very soft tip and is hydrophilic, meaning that when it touches water, it gets very slippery. Sometimes I've been able to pass a guide wire through a urethral obstruction and then use that to pass a red rubber catheter over it. So just some little tips and tricks for trying to get that catheter in when you're having trouble. One very cool option, and one you may not have access to, but I'd like to talk about it anyway, just so you have that information. For a patient with a urethral obstruction, you cannot place a urinary catheter, and you want something a little bit more robust and potentially safer than doing routine multiple cystocentesis, is a percutaneous or a surgically placed cystotomy tube. So an indwelling tube into the bladder. It's not meant to be permanent in this situation, but what it can do is divert the urine from the bladder out through that tube so you have enough time to stabilize your patient. Get the urine out, get the fluids in. All right, so now you've gotten those stones into the bladder, right? You've flushed them back in, now you've got to take them out. That's going to be via a cystotomy. Sometimes you take a pet to cystotomy and the stones are still stuck in the urethra because your emergency service or yourself, you weren't able to get them back into the bladder. So sometimes you have to do that flushing and the cystotomy at the same time. So if that is the case, you certainly want to make sure that you've draped in the urethra. Male dog, that's pretty easy. It's right in your surgical site. But in a female dog or a male cat, it's a little bit trickier. Make sure that the urethra is draped in, so their whole bum is clipped and it's in your surgical field. Make a caudal abdominal incision, isolate the bladder, place stay sutures. My preference is for a single stay suture placed in a cruciate fashion, so 2 passes through the apex of the bladder and then held with a hemostat of 4/0 small monofilament suture. You certainly may place 2 stay sutures on either side of where you're going to place your cystotomy incision. The apical one is my preference. I don't like to make a lot of holes where I'm, again, when I'm done, trying to close up and be placing more holes with my suture as I close. So stay sutures at the apex. Then make a ventral incision. Again, there are some people who have made dorsal cystotomy incisions, but my preference is a ventral incision. A ventral stab incision with a 15 blade extended with Metzenbaums. Try and find an avascular portion of the bladder if you can, but there will be a little bit of bleeding and don't be too concerned about that. Make sure the bladder is fully packed off with sterile gauze, laparotomy sponges or sterile gauze that you've counted prior to the procedure. The reason for this is as soon as you open the bladder, urine is going to come out and some of those stones may come out with it. Want to make sure you're catching all of those stones, both to count them if it's a number that you can count, but also to make sure they don't go somewhere where it's going to cause you problems in your postoperative x-rays. You don't want them to get into the mesentery or the fat, somewhere where you might be confused when you're taking x-rays that maybe not all of them are out. Then use a bladder spoon gently. The bladder spoon is very helpful to scoop out all of the stones. Feel the trigone and the apex with the bladder spoon, or if it's a larger pet, sometimes with your pinky, you can actually reach inside the bladder and palpate both the trigone and the apex of the bladder to make sure any stones have been removed. The next step is flushing. Using a catheter, flush both retrograde and antegrade. So antegrade, coming from the bladder out the urethra, flush and pass the catheter out so you can see it exit. And then also make sure you're able to flush retrograde, so passing the urinary catheter back in carefully, but to make sure that you flushed any stones that may be hanging out in the urethra back into the bladder, or little guys out the urethra. In female dogs, it's also important to evaluate the vulva and that vestibule, because stones can be flushed out and be sitting there and, same thing, give you a little scare on your postoperative x-rays. So flush is very important. Once you're confident that you've flushed out your bladder, there are no stones remaining, that's when you can close the bladder. Depending on the size of the patient, use a 4/0 or a 3/0 suture on a taper needle. Use a monofilament absorbable suture. The type of suture is a little bit up to you. Some people prefer a shorter lasting versus a longer lasting suture. Just keep in mind that urine does degrade suture faster than other types of fluids and tissues. Another question, interrupted versus continuous. Many surgeons will use a continuous pattern to close the bladder. I prefer a simple interrupted single layer closure. For leak testing, very helpful to leave that urinary catheter in. Very easy then to fill up the bladder with your hand at the trigone to occlude outflow and fill up the bladder that way. Leak testing also can be performed, for example, in a female where it's very difficult to pass that catheter back up again, by simply allowing the bladder to fill with some urine, occluding the trigone similarly, and giving a gentle squeeze. Flush everything, change your gloves. One thing that I do, not everyone does exactly the same way, but the way I was trained is also to take cultures. Culture of the urine, a portion of the bladder mucosa, just a tiny little snip, and then if there are multiple stones, crush up one of the stones into the culturette. The reason for that being that stones can hide or harbor infection, such that if the patient has been on antibiotics previously, that might have sterilized the urine, but not the entire environment of the bladder. Finally, postoperative radiographs. There are some studies suggesting that upwards of 30% of patients with a cystotomy for stones might have some left behind. You don't want that to be you. We know, and we always tell owners, once a stone former, always a stone former. That dog and cat is at risk of having stones again. But the last thing you want is to have that dog or cat come back in months or years with more stones and wonder if maybe you left some of them behind. One procedure you'll likely never have to do is a urethrotomy. It's rarely indicated to just cut into the urethra, remove something, and then either stitch it up or let it heal by second intention. This should not be done in cats. A urethrotomy in a cat will likely stricture. Male dogs with distal urethral obstructions. So if there's a stone that's stuck very close to the end of the penis, you may wish to do this. Incise directly over the calculus and just let it heal by second intention, potentially with a urinary catheter in for a few days. Again, not a good idea in cats. It can work in guinea pigs. Guinea pigs are quite prone to having cystic calculi, and if they're stuck down towards the end of the urethra, you can do a urethrotomy in a guinea pig. I hope you never have to. Unfortunately, urethrostomies are quite commonly indicated. The location of a urethrostomy, or a permanent stoma or hole in the urethra, is dependent on the species, so a cat or a dog, and you choose the location where the urethra is the widest, the most superficial, and has the least risk of hemorrhage and urine scald postoperatively. In cats, commonly perineal urethrostomy is indicated. An antepubic or a transpelvic urethrostomy is sometimes performed. In dogs, a scrotal urethrostomy is the most common location. What are some indications for urethrostomy? In the dog, a calculus that cannot be removed via urethrotomy or retrograde flushing, like we discussed earlier. Recurrent calculi that are not responsive to medical management. So a dog that has had multiple urethral obstructions from stones, you've done cystotomies, you've done surgery in the past, and they just keep coming back because of some metabolic region. Urethral strictures or injuries distal to the scrotum. Severe penile trauma or neoplasia, or congenital diseases could be another reason for a urethrostomy. The most common indication for urethrostomy in a cat is also recurrent urethral obstruction. We know that cats can be prone to recurrent UO. How many times do we allow a cat to obstruct before recommending a perineal urethrostomy? It differs by case and by owner. How many times are they emotionally and financially able to care for a cat with a urinary obstruction? Also, the more times an obstruction occurs, the higher the likelihood that the obstruction will no longer be able to be relieved by catheterization, most likely due to stricture. Scrotal urethrostomy is the most common type of urethrostomy performed in dogs. The procedure involves castration if the patient is intact and scrotal ablation, so removal of that extra tissue in the area. You'll want to, if possible, if you can place a catheter, place a urinary catheter to identify the urethra. Then perform a midline incision over the urethra through the subcutaneous tissues. Identify the retractor penis muscle and retract laterally to expose the urethra. Then you'll want to create a relatively long incision into the urethra, about 3 to 4 centimeters depending on the size of the animal. The reason for that is that will stricture and narrow down, and you want to maintain an appropriately sized stoma even after healing. To create that stoma, it's simple interrupted or sometimes simple continuous sutures, and they go directly from the urethral mucosa to the skin. This can be either absorbable, a long-lasting absorbable suture material, or a non-absorbable suture material can be used, keeping in mind that in order to remove non-absorbable suture, you're likely going to need to sedate the pet. So what is a conversation to have with the owner of a dog with a scrotal urethrostomy? Hemorrhage, bleeding can happen, usually with excitement, and it should be self-limiting once healing occurs. The urethral mucosa is very, very vascular. Licking and self-mutilation could be devastating. So these are dogs who should have an e-collar on for at least 2 weeks, ideally 3 weeks. Bruising and swelling of the skin around the site may indicate leakage of urine in the subcutaneous tissues, and sometimes a revision surgery or a placement of a catheter for 3 to 5 days could be required. Thankfully, in dogs, if the size of the stoma is appropriate, stricture is relatively rare, and these dogs can do very well. They can have some urine scald because they're urinating from an abnormal area, but again, with a scrotal urethrostomy, outcomes tend to be very good. Perineal urethrostomies, or PUs for short, are the most common type of urinary diversion procedure that we do in cats because of their anatomy. The way I explain this to owners is, we're going to make your male cat pee like a girl cat. This is a relatively technically complex procedure, and I would recommend observing and assisting an experienced surgeon or vet doing this procedure prior to trying it on by yourself. Also, performing the procedure on a cadaver, if you have the opportunity to do so, is also ideal. It's usually performed in sternal recumbency with legs hanging off the back of the surgical table, protecting the back of the thighs or the front of the thighs. The femoral nerves, don't want those to be compressed. It can be performed in dorsal if needed to perform a cystotomy at the same time. Ideally, a catheter will be in the urethra. Now, sometimes these are cats with a stricture or some abnormality of the urethra where you cannot place the catheter. Ideally, it's placed. An elliptical incision is made around the scrotum of the prepuce, and then dissection is key for a successful PU. Most importantly, you must free all of the muscle from the ischium. The muscles connecting the penis to the ischium will tether the urethra down and inwards and will create tension on your closure. Incise the urethra dorsally with a tiny pair of scissors or a scalpel over your catheter, dorsally to the level of the bulbourethral glands. Then suture the urethra directly to the skin in a simple interrupted and continuous pattern with, again, very small absorbable or non-absorbable sutures. The remaining urethra and penis distally is excised and the remainder of the incision is closed. If this made no sense to you, that's why I recommend seeing one of these done. They can be a little bit confusing, and certainly I really wanted to see several of these done before I felt comfortable doing them on my own. Similar to a scrotal urethrostomy, the conversation to have with an owner post-op can include bleeding, hemorrhage from the site, stricture. In cats, unfortunately, stricture is of a much higher risk, so they can develop a recurrent obstruction because of a stricture, as well as in the short term, leakage of urine into the subcutaneous tissues called extravasation. Similarly, that's usually managed with either a couple of extra stitches, plus or minus leaving a urinary catheter in for a period of time. Couple of other things to think about postoperatively with PUs and something to talk about owners with. Using shredded paper, so not traditional litter, is important because cats really get down there in their litter boxes and you don't want the litter to stick to those stitches. It's important not to remove blood clots from the PU site unless necessary, and again, that e-collar for at least 3 weeks. Antibiotics, that should be based on culture and sensitivity, but because infection will prolong healing and promote strictures, I will frequently start a cat on an antibiotic while I'm waiting for my culture to return. They can stop the antibiotic if the urine culture is negative, but discretion is the better part of valor when it comes to cats and PUs. One very frequent sequela of a perineal urethrostomy, which quite frankly, I'm not sure we can even call a complication, but an expectation, is an increased risk of ascending cystitis and urinary tract infections. Certainly warn owners of this and the fact that their cat could still have those signs of cystitis or feline lower urinary tract disease or fluted, whatever the internists are calling it these days, they'll correct me on that. But those cats can certainly still have all of those inflammatory signs, but most importantly, they should no longer be able to have an obstruction. So those upper obstructions that we were talking about, the ureteral obstructions, certainly you will be diagnosing these in practice, may not be treating them quite so much in practice, but this is important to just know a little bit about what happens when a ureter is obstructed. What happens then is the urine backs up into the kidney, creates dilation of the renal pelvis, and then can actually kill off the renal tissue as pressure builds up. Again, if both of the kidneys are abnormal, which commonly happens in older cats with chronic kidney disease, they'll develop azotemia and clinical signs. Occasionally, if this is an acute obstruction and the other kidney is normal, you may not notice anything in these guys. Sometimes you'll do an ultrasound or an x-ray in a cat and you'll find that one of the kidneys is a tiny little walnut. It's very shriveled. And what we think might have happened is that there was an obstruction or a stricture at some point and that kidney shrank down to nothing and we never knew. The treatment is dependent on what options you have in your area. A ureterotomy, so opening up the ureter itself and removing a stone and stitching it back up, is one method, but it does carry some high risks, versus ureteral stents, or subcutaneous ureteral bypass. Again, this is something that will depend very much upon what is available to you in your geographical area and what your clients are open to in terms of travel and referral. Our last topic in the module on urinary surgery is urethral prolapse. Unfortunately, with the popularity of our adorable brachycephalic friends, the French bulldogs and the English bulldogs, we are seeing an increase in incidence of urethral prolapse. What that is when the urethral lining is able to evert or come out of the tip of the penis. We think that there may be some correlations to being brachycephalic itself, so increased work to breathe and abdominal pressure. Certainly we'll want to make sure that we've ruled out any other reasons for straining or increased pressure with urination, like urinary tract infection or stones, obstructions, anatomical abnormalities, that sort of thing. However, a lot of urethral prolapse are what we would call either idiopathic or just breed-related. Because these urethral prolapses can be painful, they can cause necrosis and death of that prolapse tissue, and they can cause a urinary obstruction. These are considered surgical. There are two common methods for treating a urethral prolapse. For a minimal amount of tissue prolapse that appears quite healthy, urethropexy is an option. So placing 2 to 3 sutures evenly placed around the penis through the body of the penis using a special instrument called a grooved director or a modified urinary catheter, placing mattress sutures that hold the urethra mucosa in place, hence pexy. If there's a lot of tissue that's been prolapsed, particularly if it's unhealthy, then a procedure called a urethral resection and anastomosis will be required. In this procedure, similarly, place a urinary catheter to identify your urethral orifice, and then using very, very small absorbable suture, monofilament, place interrupted sutures in a cut and sew pattern, resecting the prolapsed tissue and suturing the urethral mucosa back to the skin of the penis. Occasionally, with recurrent urethral prolapse, both of these procedures will be performed concurrently. I did one 3 days ago on a dog who'd had a very successful resection and anastomosis performed just the week prior, but more tissue prolapsed out. So we had to repeat the RNA as well as perform a urethropexy. What are other ways that you can increase your success with surgery for urethral prolapse? Trazodone, gabapentin, acepromazine, butorphanol, all of the things that you can do to keep these patients calm. They tend to be very young, intact males who are quite excitable. There is a study suggesting that neuter may not be as protective for recurrence as we once thought, but we still recommend neutering these dogs because as they get excited, bleeding and prolapse can be of higher risk. The risk of recurrence is high. It's around 50%. But by doing these multiple procedures, you can decrease the risk of recurrence, and overall, in the long term, most of these dogs can have resolution of this. Just may take a couple procedures to get there. That concludes our module on urinary surgery with a focus on emergency procedures.